Hello, and welcome to today's Center for Healthcare Strategies webinar made possible by the Robert Wood Johnson Foundation on approaches to extending complex care models into the community, emerging evidence. This webinar is part one in a two-part series that explores how providers are building on existing complex care programs to extend care beyond the walls of the clinical setting and into the communities where people live, work, and play. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us. We hope you will take a moment to do this. I will now turn the webinar over to Caitlin Thomas-Henkel, Senior Program Officer at the Center for Healthcare Strategies.
Thanks so much. Good afternoon, everyone, and thanks for joining us for our webinar that's been made possible by the Robert Wood Johnson Foundation. We're really excited to share some lessons learned and findings from one of our initiatives. And first, I'll go through a brief run-through of the agenda. We'll first start by featuring one provider's strategies for supporting outreach workers on complex care teams, followed by some insights from the program evaluator, and then a question and answer session. Next, we'll share some additional insights from another provider in building a business case for community-based complex care intervention. Our evaluator will also lend some insights on the evaluation efforts. We'll then leave ample time for question and answer. As a quick reminder, please remember to submit your questions via chat, and please mute your phone line. A little bit about the Center for Healthcare Strategies. CHCS is a nonprofit health policy resource center dedicated to improving the health of low-income Americans. We have three main areas: enhancing delivery system and payment reform, enhancing access to coverage and services, and integrating services for people with complex needs. Today's project is focused on that third bucket, integrating services for people with complex needs. A little bit about the project. This is a two-year multi-site initiative that's aimed at refining and spreading effective complex care models for people with complex health and social needs. This project was made possible from the Robert Wood Johnson Foundation. To your right, you'll see several domains, some of which we'll talk about today, specifically the care model enhancements, as well as the financing and accountability. We're thrilled to share insights from this project as we've been working on it for several years, and we're really excited to have the providers on board as well as our evaluator. So first, I'll do some introductions to the folks who will be on the webinar today. Sandy Gronwald is an expanded care team physician at ThedaCare Health System in Appleton, Wisconsin. She is joined by her colleague, Lori Moore, project coordinator at ThedaCare Health System. Kim Lewis is a program and community outreach coordinator at VCU Health System. And finally, our project evaluator is Dr. Derek D'Elia, Director of Health Economics and Health Systems Research at MedStar. Okay. All right, Sandy and Lori, are you there? Please remember to unmute your phone line.
Okay, thank you, Caitlin. We appreciate the opportunity to share our learnings with you today. We're located in Northeast Wisconsin, serving 240,000 patients annually. The next slide shows our 7 hospitals that are serving this population. ThedaCare started the journey into population health and complex care in 2013, and we launched our team-based care model in 2014. The results were very good, and our leadership team were pleased with the outcomes. However, from a business perspective, we were not able to sustain that program due to cost and lack of reimbursement for those services. We stepped back, took those learnings, and as part of that, did a gap analysis and found that we needed to provide in-home assistance to our populations who were medically and economically most at risk. These were patients who did not meet qualifications for existing in-home care services. Next slide, please. We needed that service to flow into our existing programs and focus on patient-centered goals. And from that came our community paramedic program. We knew we needed a program to help coach and support our patients and connect them to community resources. Our community paramedic program focuses on building the relationship and partnering with our patients and guiding them to their goals. We've built our program to communicate with the multiple care teams so we share a similar message with our patients. The next slide shows how we do this in the EMR. Our communication is clear, concise, and it's information that's easily located in the patient chart for all team members to be able to see and to make sure that we're sharing the same message with our patients. We evaluate the social determinants of health and complete the questionnaire with 19 areas on it. This gives our team the opportunity to connect our patients to resources they may be in need of. It also helps create a strong bond between our teams and help our patients see that we care and we're there to help support them. We believe that there are several keys to our success with patients. The first being building the relationship, connecting the patients where they are at and helping them work to build their independence and connection to resources. We want to empower them. Second is using a trauma-sensitive approach, understanding that they may have adapted a coping mechanism that may be contributing to their health condition. We use a motivational interviewing style to coach them to resources and to assist them when they're ready to work on their own goals and take small steps to achieve success. So that's some background on our initial steps that we used to engage our leaders. We learned from things that we had done in the past. We knew what we needed to adjust moving forward. And so I'm going to turn it over now to Lori to share how we use data to engage our hospital leadership.
Thanks, Sandy. We did use many forms of data to present our program to our peers and our leaders throughout our organization. In general, they did feel we were doing the right work, but there's a lot of right work going on out there. So how do we decide and help them decide what we can do and what we can actually pay for? So we used quantitative data heavily supported by qualitative data, and Derek will show you the specifics of that quantitative data in a little bit. So we used both to demonstrate the level of impact of the program and create confidence that it was repeatable. We used some general program data as well to show some financial responsibility in ways we developed the program, such as studying and keeping to our short enrollment period. We created independence with our patients and not a reliability on an ongoing resource. We were also able to show increased patient engagement with high referral rates, completion, etc. We used our financial data to show volumes of lives that we touched per FTE, and we'll show that in our performance slide a little later. Okay, so quantitative data is essential in proving the case, but it's maybe limited in its ability to demonstrate real patient impact. So if we show quantitatively that their utilization rates went down, are they really any healthier? Are they better off? Was it due to some other factor? So the stories and testimonials can more directly connect to the work we've done with the data and sell the program. And it can also make our leaders take notice and give them some aha moments. So the next slide is a brief summary of one of these patient stories. This is our real community paramedic, one of our real patients. He was seeing his physician and his care team regularly, doing the testing at home and in the office that he needed to do. He was educated, had adequate health literacy, yet something was still missing. So we were able to demonstrate within our story and our work with him that after our visits, he was able to hit targets and maintain them. With that came the ability to discontinue 2 medications at a significant cost. So in addition to his reduced complications from diabetes, he was also able to get an orthopedic surgery. He was previously denied based on that. So on the next slide, you will see his statement in the upper left. There's no way I would have been able to do this on my own. There's no way. So this demonstrates he is healthier and he is better off and his family is better off. And you can see another statement below from the wife of another patient, how she's better off too. She can actually leave her partner at home to take care of herself and get to her own appointments. So these statements can really hit home for our leaders, as they most certainly want our patients to be well, but it's impactful stories for our community to hear. Other statements that are important to collect and share with our leaders are those that come from our team members themselves. How do they really feel? Would this program be difficult to spread and sell to them? So on the lower left, you can see a statement from one of our RNs confirming and supporting that this is reiterating what they do. In the upper right, you see a statement from a physician stating that they're finally able to have the barriers broken down that have been standing in their way and preventing them from reaching goals for their patients. So in times of employee and physician shortage and stress, these are key impressions for our leaders to hear. So we have the sell from a patient value perspective, but we still need to build the case with how it fits into our organization. So kind of really starting from the top, we align with other system initiatives. And I think most of us can find that it's fairly easy to align with our missions and visions. They're broad, impactful statements, but all of our work can really reflect upon them. So we align with specific system initiatives and strategies and more than one of them, and these were some of ours that we aligned ourselves with. So the next slide shows how we built a program in a way that was sustainable, aligning with our transitions of care strategy. We embedded our program within an organizational structure that was already in place. So there was no new team, no new silo, no new leader needed to support the work. So this makes good business sense. The next two slides go into how we broke down the business case for our leaders. It was quite a process. It takes a lot of time to understand and construct a model. So we got together with the ACO, showed them numbers, actual cost savings and studies, and the population that we had already served. And then we could really continue the conversation and partnering on identifying potential populations that we could or should serve and get a pro forma developed. The next slide shows some of the discovery work that we actually got from them. It's really important to get their information as well as ours. When looking at utilization, populations that we served were populations that can and do use other systems. So that's data that really only they can have and then provide to us. It really validated our own work as we compared it. So that was extremely valuable and necessary information for our leaders, as well as our own understanding. And we were also fortunate enough to come across a great learning on how the ACO teams can discover and pull information that we can't easily pull. We had an impression about the impact of behavioral health on our patients that were being referred, and this confirmed that. So this might end up leading to future care models, and most certainly speaks to the importance of our trauma-informed care approach that Sandy noted. Okay, the next slide, this is really getting to the dollars and cents of our ACO reimbursement and payment model. So we took out our specific info, but wanted you to see how we incorporated some of the elements to put this together. We first considered the payers as directed by our ACO leader. This started with the patient that would benefit most from our work, as well as the contracts that could give us the opportunity for the most favorable performance so that we can spread further. We pulled in finance as well to build this pro forma, added in our assumptions about utilization reduction based on our program data with an agreed upon degree of confidence that we'd be able to sustain that. And we extrapolated the potential impact on the attributed lives in these contracts. We created scenarios on the right based on the various model options of spreading or dedicating the resources to specific populations of payer or utilizer. And we could see the numbers we needed to achieve to either break even or actually have a bit of a financial gain with that contract. So some final key points in regards to aligning with ACO leadership. It is really important that we understood their world as much as we could. This was in regards to their contracts, per member, per month versus attributed lives, shared savings concept, upside downside priorities, and the complexities of the model. So we really had to do that to agree upon a degree of confidence in the favorable pro forma as we presented that to leadership, and really assure we're not driven solely on our passion for this work. Again, this was a process. There was many visits and conversations about the information available, and we just kept pushing for more and more data. We had ACO leadership present along the way, in particular during the visit with Centers for Healthcare Strategies. They were able to engage in strategy conversations, and they were also the ones that had the power to make things happen and not just relay their information upstream. They even had conversations that were above us, but that was fine. We caught up later. This just made it possible for our leaders to propose this happening today rather than someday for ThedaCare. We'd also recommend having your ACO team share results with your payers. Once one of our payers heard about us through our ACO team, they were quite impressed with the work and asked us to present at the ACO State Summit in Wisconsin. These conversations likely will help other organizations in the state move forward, and it certainly impressed upon our own leaders and gave relevance to our work and stated that we were being innovative leaders in the state. So in summary, we were able to demonstrate alignment with leadership strategies. We had a well-defined plan. We had data-driven successes at a relatively low upfront cost, and with favorable outcomes on value-based contracts, allowed us to keep moving and attain final approval for the program's future.
Thank you so much, Sandy and Lori. Next, we're going to shift gears and have the lead evaluator, Dr. Derek Valia, share some initial evaluation findings. Then following that, we'll open it up for a Q&A discussion so that you can ask your questions to the ThedaCare team. Derek?
Thank you, Caitlin, and good afternoon, everyone. Before I jump in, first I just want to acknowledge my colleague Jolene Chow from the Rutgers Center for State Health Policy, who's been working very closely with me on all the evaluation and technical assistance work for this project. And also, as Lori mentioned, the evaluation work here has really been very collaborative between the formal evaluators and the people at the sites themselves. The approach here has been to really work with the sites, try and draw on the resources that they have available for evaluation work, whether it be data or other things, and really try to learn as much as we can together as quickly as possible within the project. So if we go to the next slide, this is just an outline of the approach for ThedaCare, which is really a mixed methods approach with some quantitative and some qualitative information. So the quantitative part is information pulled directly from the electronic health records at ThedaCare. And here we're looking at people who are enrolled, really people working with the community paramedics from January through August of 2017. For some of this, we'll use a comparison group from ThedaCare's facility in Neenah, Wisconsin, in their internal medicine clinic. And for some of the analysis of diabetic care, we have some matched controls, which really ThedaCare put together, and as evaluators, we gave some advice and commentary around that. So our observation period is to try and understand a little bit about utilization 6 months before and after enrollment, and for the diabetic group, the A1C measures within 3 or 4 months of working with the paramedic. Also, we did some qualitative analysis where we went out and we talked to people at the ground level at ThedaCare, certainly the community paramedics, but other people on the care teams to try and understand how the work gets done and what are the major themes, what are the major issues that come out in talking to people across the entire care team about how all this process works and what it looks like is coming from it. So the interviews were recorded and transcribed. Jolene and I analyzed them independently, and then came up with what we consistently found were major themes from the interviews. So we can go to the next slide. So here's just a glimpse at some of the demographics of the patients we're looking at ThedaCare. A little more female than male, and a good representation. Almost 2/3 are covered by Medicare, and this does include dual eligibles. We didn't break out the dual eligibles just because the cell sizes get really small, and good research practices, we don't want to show numbers too small, just out of concern for patient privacy. So we can go to the next slide. So here's a look at some of the impact of what they're doing at ThedaCare for diabetic patients. So this is a group of 18 individuals with very high initial A1C levels above 9, and these were matched with people who also had high A1C level and similar in age and sex. And what this is showing you is the change in A1C level. So these people start out at levels that are really high. We would like that level to come down. And that's really what we're seeing for the people in the intervention who got the community paramedic intervention. Those are the blue bars. So you can see for each individual, each column is really a matched pair. The blue is the ones who got the intervention. The red is the similar person who did not get the intervention. And you can see the numbers for the ones with the intervention are all negative and pretty large. And for the comparison group, it may go up or down. Not too much is happening, but I think this is actually pretty striking for such a small group of people. Even with such a small group, if you did statistical tests, this would be a real statistically significant difference, showing that there's something really going on here. There's really a decline in A1C level for the people who are in the intervention. Pretty strong results for such a small sample. We can go to the next slide. So here we look at people who were, targeted for intervention because they were high users of the emergency department. And here, high users defined as having 3 or more ED visits within 6 months. So here we have 19 people in the intervention and 20 in the comparison at NINA. And you can see in the intervention, there's a clear drop in emergency department utilization. For the comparison group, it really doesn't change very much. It looks like something real is going on with emergency department visits for the people in the intervention. Similarly, inpatient admissions, we see a similar thing happening. For the comparison group, it's really not changed at all. 180 days before and after. But for the intervention group, there's a clear drop in hospital admissions. So another pretty clear finding there. We can go to the next slide. Here we have just some highlights from the qualitative analysis, some of the major themes that came out of our interview work. So the first theme really has to do with how the community paramedics are used. And so they're deployed when often when clinicians see that there's a gap in patient care, something is really not working well for the patient. So have the paramedics come and visit with the individual and really follow up, do a detailed investigation looking at issues that really can't be addressed in the clinic setting. Specifically, what's going on in the home, how the home is organized, the person's everyday lifestyle, and things like that. Another theme that came up very often is the issue of medication compliance, where you send a paramedic into the home, and they often find that people are taking multiple prescriptions, and sometimes they're skipping doses, or they have old medications and they're confused about what to take and when to take it. And the paramedics will go in there and really help people get organized with that. Third theme has to do with just the appearance of the paramedic coming into the home with the paramedic uniform. And this was raised pretty often where people felt that patients respected the uniform and had a real comfort level with it. You know, the analogy is like paramedics are kind of like police officers and firefighters, and you go to them when you're in trouble, when you need help. And so having someone like that come into the home help people feel comfortable, and really opens up the line of communication in a way that they wouldn't get talking to a doctor in a clinic. And I think it's an interesting point because it's kind of a contrast with what happened at VCU, where you know, I'll preview those results a little bit, but patients there kind of felt like they were more comfortable seeing someone who's not in uniform, who kind of looks like a regular person, so to speak. And that might have something to do with just, you know, differences in demographics and geography. And I think it speaks to the point that you really want to know your patient population well, so you can serve them well and really gain the trust and comfort level that you need to do this really hands-on, really very, very personal work with patients. Another issue that came up in ThedaCare is this idea of transitioning from being an ordinary paramedic to being a community paramedic. Some people might think that it's just kind of a natural transition, that, you know, any paramedic can do this, but that's really not the case. The community paramedics really have a different temperament from traditional paramedics, where, you know, traditional paramedics are often moving quickly. They're trying to triage and resolve an emergency situation and then move on. And really, community paramedics are kind of doing the opposite. They're trying to slow down. They want to know what's happening with the patient long term on a day-to-day basis, so they can do a better job at managing their health on a day-to-day basis. It's a different temperament, and it's a different set of skills, which, you know, we could talk about later if questions come up, but that stood out in many of the conversations we had with the care team. And then the final salient theme is that in this model in ThedaCare, and I think Sandy mentioned this as well, they really have a well-functioning electronic health record system, and that's where a lot of the communication takes place. Community paramedics can interact with individuals in the home and then get into the EHR and make some notes, and then at a later time, a physician can just see the notes and be aware of any new information that comes up the next time the person comes in for an appointment. You know, other places do more with team-based huddles and in-person meetings and things like that. But it really stood out at ThedaCare that the EHR is functioning at such a high level that you don't necessarily have to have so much in-person interaction within the care team. A lot of it can be done in the EHR, and nobody ever said anything like, we're missing information and I don't get it in time. The information gets there, it's in place, and then you have a standing record of what the community paramedic did, or the paramedic can look up what the physicians are doing, and they could address relevant issues with patients they talk to in the home. So that's what we have at this point for ThedaCare. I can stop here and then turn it over to Caitlin.
Derek. We have a number of questions, so just a reminder, if you have a burning question, please put it in your chat function. The first question for Sandy and Lori is, how was your program funded?
We were fortunate to receive a grant through the Robert Wood Johnson Foundation to create the community paramedic program. So we initially had started on a journey with population health and complex care, and had great learnings from that, which we were able to apply toward creating our community paramedic program. So that funding helped us get the program started, and then once we had results that we could prove that the program was working, we were able to get additional grant funding through our ThedaCare Foundation.
Thanks so much, Sandy. And just one quick follow-up. You're also continuing to work with the ACO, is that correct, to look at opportunities under shared savings for components of the CP program? Correct me if I'm wrong there.
Yes, correct. As we move forward now that the grant has ended.
Terrific. All right, we have another question. This one relates to enrollment criteria. Do you have specific criteria for enrollment or referral into the community paramedicine program?
Yes, we do. So one of the big things that we use is provider intuition, because they often know their patients really well. The other criteria that we look at are patients who are not able to have home health services or who have perhaps declined it for some reason. So one of the things when we set up our program, we wanted to make sure that we were not competing with other resources that were already available for patients in the community. So patients with medication complexity, so when there's concerns about medications, is probably the other big thing. Sometimes we get referrals for patients who are visiting the emergency department frequently, and the team is hoping to get some additional information on how we may be able to assist that patient, and what factors, what variables may be going into them needing that resource, and then connecting them with appropriate community resources if they're interested.
Great, thanks so much, Sandy. We have a question. So why community paramedics? Why not use nurses or social workers? How are they different?
Great question. We had done work initially with a complex care team that consisted of an RN, a social worker, a pharmacist, and a behavioral health therapist. And what we found was that for whatever reason, our patient population just was not comfortable with those team members coming out into their home. We have an ambulatory care team that now has started, and that's going well. But our initial work, we were not able to create that connection with patients. And so for whatever reason, and we understand that this is the case across the country, people really are very accepting of paramedics. Many of these patients have had or worked with a paramedic or had a paramedic come to their home, or a neighbor or someone else. And so they feel very comfortable. The other thing is that paramedics are used to coming into these homes in emergency situations. So when they come into a home, they're not doing a safety check. They're not judging these patients in any way. They're coming in, that's already built into how their workday goes. So they come in and they're just so comfortable with these patients. And so we've taken those learnings, and we are using that as part of coaching with our other team members. But that was one of our big takeaways, was how comfortable people were. So I saw one of the questions about the uniform. In our area, Gold Cross is extremely well respected, and so we have not had an issue. I know other parts of the country, obviously police are, you know, there's many issues there, but for us, our Gold Cross is really very well respected. They're very involved in the community, and so people, for the most part, are really very comfortable with them helping and connecting to community resources and helping them navigate our health system.
Thanks, Sandy. So I have a staffing model question. It's a three-part. Are CPs available 24 hours a day? If not, what are their hours? And how many CPs are employed? And what is their caseload?
Start out with their hours. We are not 24 hours a day. Yes, not sure if we'll ever get a model that's like that. these are not acute visits. These are scheduled, maybe a day or two out, maybe a week or so out. So currently we have scheduled blocks, let's say open from 8 a.m. to 8 p.m. Monday through Friday. But once our paramedics have met these patients, if the patient needs to meet at 7 due to work or other commitments, they'll make arrangements for that. But it's currently like an 8 p Monday through Friday. The number of community paramedics, we currently have 2 paramedics working 40 hours a week each, roughly about that. So 80 hours a week of service. We're hoping to add another to our system by next spring. It takes a little while to get the education portion done from the community paramedic program. And Wisconsin is a little behind other parts of the country in regards to this program. So our paramedics have to currently take a program through Minnesota. And the last question was around caseload. I'm trying to just recall the last, roughly they carry between 40 and 60 patients at any time, and that usually keeps them pretty busy. It's maybe a little less than another one of the care management team members that may see patients in the facilities or on phone calls. So when they're constantly doing their visits on the road, that's about what they can handle. And it seems to be about right. They'll see patients maybe once, 3 times, maybe 7 times, maybe a few over that, but keeping the patients to roughly 3 to 4 visits at an average can kind of help them keep that caseload, and we'd like to see like the high 50s.
Great, thanks so much, Sandy and Lori. We have a question shifting gears a bit, financial. What is the nature of the financial services agreement with the community paramedic program? I'm assuming this is Gold Cross they're referencing here.
Yes, it is. We contract for their services, and they kind of roll up everything into a bundle for us. So their fuel, their maintenance, and their hours.
Great, thank you. Another financing question. Can you speak a little bit more about your ACO? What specific populations are included? Medicaid, commercial, dually eligible?
We have all of the above. So in particular, the contracts that we initially are hitting are Medicaid, Medicare, and dual, but we're having conversations currently with a couple of the commercial payer contracts to see where they are. They are a highly upside down contract in terms of reimbursement. So we're starting work on that one as well. But currently, the top ones that we are partnering with are those top 3.
Great, thank you so much. We have a question now that's related to care management and patient engagement. How do you measure changes in patient empowerment and self-sufficiency?
That is a great question that we struggled with how to measure. So we do not have data for measurements on that. What we looked at trying to capture on that was their no-show rate, and did that change with involvement with the care team. Also looking at health maintenance things, how engaged they were in those things. But we did not have a good resource that we were able to build in it. And we were a small but mighty team, and that was not, we didn't have the resources to be able to follow that. It's a great question. Thank you.
If anybody has a great way of doing that, we'd love to hear about it.
We have looked into the PAM tool, but just from a cost perspective and from a time perspective, we were not able to use that.
Thank you so much for your honesty and for putting a shout out there to others if you want to chat in any tools that work well for your program. So we have one final question for the ThedaCare team. Are community paramedics trained in interpersonal relationship building in a way that may differ from other providers?
I guess I don't know the answer to that question. That's a good question for our paramedics to answer. Through their education as a community paramedic, I imagine they have some of that.
I would say that when we created the program, one of the specifics was that we took our team to a trauma-informed care conference to hear from some of the experts from across the country on taking a trauma-sensitive approach, looking at that question of not what's wrong with you, but rather what happened to you, making sure that we really were not judging our patients and that we were coming at it just really to be there to guide, to help, and to help understand what their goals were. And if we understand that, then taking small steps to help them move forward. So I would say that's one of the key pieces that our team uses as an approach, as well as motivational interviewing training. So those are two of the key elements that I would say they have, along with their basic safety training that they have as paramedics.
Thank you so much, Sandy and Lori, for that excellent presentation. And Derek, thank you for your reflections on the evaluation findings to date. Next, I'd like to pass the baton to Kim Lewis at Virginia Commonwealth University Health System. Kim?
Thanks, Caitlin, and good afternoon. Just as a little background, Virginia Coordinated Care has been in existence since approximately 2000 and has served roughly 89,000 uninsured individuals in our community. It's the larger program under which the complex care clinic exists. So we're going to focus on our Take Care program and our complex care program today, but I wanted to give you a little bit of background to know that we've been in this business since 2000. The complex care clinic was designed to enhance the management of patients with 5 or more chronic conditions. In other words, the sickest of the sick. We focus on the population with the highest cost and highest utilization. Our goal was really our triple aim, you frequently hear the triple aim. We're looking to improve better care. We want to decrease readmission rate, inpatient need utilization, better health, improve clinical outcomes such as improve hemoglobin A1C, hypertension, cholesterol levels, BMI, lower costs, reduce total cost of care. Next slide, please. The program principles that we looked for when we set up the clinic were coordination across the care continuum. We wanted to access medication management, behavioral and health services. We wanted to coordinate post-hospital, hospital and longitudinal care, leverage information technology. We wanted to and have achieved PCMH certification, use data to measure and improve performance, develop interventions to address social issues. These were the guiding principles that we wanted to create and maintain the clinic. Our complex care clinic is supported by an interdisciplinary team. It consists of physicians, nurse practitioners, social worker, clinical psychologist fellow, pharmacist, clinical nurse, RN case manager. And you'll notice here that I have our medical outreach worker and our community health worker in 2 different colors. The purpose for that is that we actually do use 2 different types of outreach workers here. One is internal to our clinic, who works with our patients in the clinic as part of the team, and our community health workers that we're going to talk about in the rest of the presentation here connects this outreach worker into the community. They connect our patients into the community. They do home visits and see them out into the community, into their home environment. So one is connected to the team as part of the team in the in the team, and the other one continues with the patient into the community. All right, our 2 community health workers, here you'll see Brianna and Kaswana. We have 2 full-time community health workers. They were both graduates of VCU. They have degrees in health sciences. They are certified in the state of Virginia. Examples of the competencies that they have are that they are able to identify problems and resources that allow them to help our patients solve problems. They're able to help them identify goals needed to help support their families and help them to navigate their goals throughout the health system to work independently. They are able to help our patients enroll and to empower them to become active participants in their own health. They are able to help them manage data and just to bring us back to where we were, our medical outreach workers in the clinic and outside of the clinic work together as one team. The inside outreach workers and the outside outreach workers are an extension into the community, just to sort of level set and bring us back to where we were. Next slide. All right, so through the funds that we received from the Robert Wood Johnson Foundation, we were fortunate to be able to add 2 outreach workers. They are 2 full-time community health workers, both graduates from the VCU Health with degrees in health sciences. We're very fortunate in an academic environment to be able to recruit interns that have the opportunity to learn about outreach work. So I'm constantly able to recruit interns and expose them to outreach work. So I'm always able to train them and have the opportunity to expose them to the field of outreach work. I did see already in the chat room a question about do I require a degree for community health workers? It's not necessary that they have a degree, but I do prefer a degree because our community health workers are very savvy in navigating healthcare systems. They're very savvy with data management, and those skills come a little bit easier for some of our outreach workers when they have that, but it's not necessary. Next slide. The day-to-day work of a community health worker. Each day, our community health workers start at 7:15. They're involved in a daily huddle with the team that we talked about earlier, where they receive a daily report of any of our patients that come into the emergency room or are admitted as in an inpatient situation and look to be appropriate for our Take Care program. If the patient is deemed appropriate, meaning that would benefit from our more intense interaction with our community health workers, the community health worker engages the patient at the bedside or calls them and sets up a home visit within 2 business days. Within those 2 business days, they make an initial home visit. They make a home visit within 1 week. They come back to the team and they sort of report in what those initial findings are. With the team approval, and they work with our medical director, they set up an initial 6 weeks visit. They report back into the team any of the findings, what the person's home situation is, what their issues are. Again, these are community health workers. They're not clinicians, so they're looking for home issues that might impede the medical work that the team is trying to do with them. So if you're thinking of this community health workers as the eyes and ears of that clinical team outside of the clinic setting, what is going on in the home that might impede the work that the team is trying to do? Are there other things going on there? Are there barriers that might keep the person from achieving optimal health? They report back into the team, either in the daily huddle or in the weekly huddle. Based on the team's advice, they continue to work with that patient for 6 weeks, 12 weeks. Ideally, we have patients that work with our team longer than 12 weeks. We have patients that work with our team sometimes shorter than 12 weeks. It just depends on the individual situation. Once the patient has achieved the goals that have been set for that patient, they are transitioned back to the outreach worker that is considered the internal medical outreach worker. Next slide. So while this is busy and fun, it just sort of gives you an idea of what has happened in like a 12-month span. So you can see when we talk about beyond the clinic walls, this is just a snapshot of the work that Brianna and Kaswana did over a 12-month period. So you can look, they engaged patients at the bedside roughly 83 times, and just kind of walk through. They engaged patients in the clinic setting They engaged patients in the home over 360 times. They engaged patients by telephone 316 times. And of course, they did that much more than that. But as we go through the slide, you'll see there's some productivity measures and ways that they count encounters. So this just gives you a rough idea of what they did. They engaged patients at community partner sites. They escorted patients to community resources and other specialty appointments when needed. I really wanted to focus on the very bottom, engaged patients at community partner sites and escorted patients to community resources and our specialty appointments as needed. What's important about those is that they're doing that because the patient may have mentioned in a conversation or in some setting that they had some social need or some situation that they really needed to be addressed and could be helped through a relationship or at a community setting or a community organization. That may have come through just a conversation, or it may have come through part of their onboarding where they complete a social needs assessment as part of their onboarding. Now, Derek, when he does his part of the presentation, is going to talk in more detail about that. But in the next slide, you'll get a look at the actual screening tool that Brianna and Kaswana use to assess their social needs. So I'm not going to go into a lot of detail about that because Derek will talk about the results, but I did want you to at least get an idea of the kind of screening tool, the kinds of assessment that they did use. So you can get a look at that. Next slide. Next slide. All right, one of the unique features of our program, and one of the things that I really use to work with my team, is a reflection log. A reflection log is a brief voice recording which is used to monitor our outreach workers' weekly patient interactions and experience, and to really manage the employees' needs. So at the end of each week, it's a 5 to 8 minute recording that each of the community health workers do. The purpose of it is to capture their experience and learnings and to help manage the burnout and the stress, like always trying to make sure that they're doing okay in their jobs. My team is fairly close to me, so I do have the opportunity, and fortunately they're close enough that I engage with them on a regular basis. I do know that there are community health work teams that are pretty remote and they're spread out, and so it's sometimes difficult to manage them when they are that way. You don't see them often, but I am fortunate enough that they were close enough to me that I did see them. But I did use the reflections to more or less hear things. It's not so much what they said, but it's sometimes what they don't say that you hear in a recording. How they did this was each week they would use the app on their phone, on their cell phone, and they would make a recording, and they would share it, save it to a folder on their computers, and then I would go in at the end of the week and listen to their recording. When we first started doing this, we had some basic questions that you would imagine that they would record. Things like, what worked well this week? What didn't work well this week? Did you have any challenges with your technology? Did you need any additional supplies or equipment? And as you can imagine, they would answer things like, what worked well? Oh, I had a hard time juggling my calendar. My hotspot didn't work. My laptop didn't work. I went to someone's house, they weren't home. It's very much about logistics and about, the mechanics. Nothing really special. It was pretty much about the mechanics of their job. And I could see them growing in their job, but it was more about the mechanics of doing their everyday job. Next slide. I call this slide the evolution. We met with Caitlin and the team, and we started to talk about, okay, they're a little bit more sophisticated in their work, and we're starting to see that I am getting those same answers, and I really want to know how they're growing in their job and how they're growing in their work. So we really started to work with Derek and the team, and we started to work on the questions, and so the questions evolved. Now the questions were, what would you consider a particular success this week? Was there a particular situation this week that required more of your time than you expected? If so, what was it and what was the outcome? Did anything happen this week that made you feel especially stressed or frustrated with your work? Did anything happen this week that left you feeling especially proud or enthusiastic about your work? And before we move to the next slide, I just want to hold right here for a minute. And so now you can see that these questions here now give you pause, because even, you know, if you think about anyone that's on this webinar, if you had to answer these questions about your own work, you'd be challenged. And imagine if you had to answer these questions each week about your own work, you'd be challenged to answer them. So if you just think about the last question there, did anything happen this week that left you feeling especially proud or enthusiastic about your work? So before we go to the next slide, I just want to give you a little background. Brianna Ricks, one of the outreach workers, went to visit a patient. And when she got there, the patient didn't look good to her. So what they do is when they go to the home visit, she was a routine home visit, she went to visit the patient, and he didn't appear well. He was a little slow in answering the door. When she got there, he seemed confused. He seemed short of breath. And what happens is when they go in, there's always a nurse in the clinic that is assigned to her. When she got in, he let her in. She called back to the clinic and told the nurse what she saw. The nurse said, call 911. She told the patient that she was going to call 911 and he needed to go to the emergency room. Next slide. So here's Brianna's words. Brianna is on your screen on the left in the red pants. So the question, did anything happen this week that left you feeling especially proud or enthusiastic about your work? Brianna's answer, I was most proud of the fact that the patient listened to me. When I saw that he didn't look good and didn't seem like he was feeling well, I called our nurse. She said to tell him to go to the ED, and he listened to me. I found out later that while he wasn't admitted, his blood sugar had been elevated. I'm glad he listened. They don't always. So, you know, that was very powerful and meaningful for Brianna in terms of her week. So if you think about like how I hear this, in this case, I knew that happened when it happened because it was a big deal in the environment and in our clinic. So, you know, when that happened, I knew. But had I not known that day, that would have been a call to Brianna immediately about her experience, and we would have kind of walked through that in terms of how she felt and how she managed it and how she worked with that patient. So that's a great example of how those questions evolved and sort of helped her, you know, walk through her day. Next slide. So here's just a quick overview of how we manage the community health worker productivity. Again, it's not so much to keep them in line or keep them in control. We use it more as a way to just sort of track their hours and also to help them if they're having problems with managing their calendars, managing their workload. They automatically get an email each week that says you need to track your productivity. It's sort of a prompt. They click on the link, they go in, and they calculate how many hours. We have a common definition of each of these categories, so they're all thinking the same way. They go in and track their hours, so it equals 40 if you look at it from the far right, and it totals up to the month. So that's just an example of Brianna for 1 month. Next slide. Community health worker support. We support them through team building activities with other outreach workers, through monthly meetings and activities, both structured and non-structured. So things that you would think about, both, you know, educational activities, silly things, lunch activities, educational activities at the individual and organizational levels. Though this grant provided the opportunity to have 2 community outreach workers, I have 8 in all. They all are certified in the state of Virginia as community health workers. Many of them are in school. They have undergraduate, graduate degrees. I encourage them all to go to school, receive certifications. I'm always on them to go to school. They have staff recognition opportunities. Brianna, for the example of that I gave with the patient, was like the hero and the star, the big save as a result of her experience with the patient. We have monthly stars, one-on-one discussions with them. We do problem solving when they're having challenges with patients. We do personal career planning type activities. When I hear their reflections and I hear challenges that they're dealing with, and sometimes it's more important, as I said, what they don't say as well as what they do say. I have conversations with them either in person or send them an email based on their reflections and what they're talking about. They each have a special projects, and sometimes it's not even at all related to community health work, but it is always related to a strength that they have. For example, I have one that is very, very good at event planning and gathering people. And so I always give her projects and assignments that have to do with event planning and, party planning. Things that would pull a group together for some fun sort of group event. And so those are the things that sort of boost them up. And so even though they might be tired, they might be frustrated, or they might be fatigued and feel like it's just another task on top of another task, once they get involved in it, they do feel excited and happy because it does pull out another skill set that they didn't know they had, or they feel excited about doing it. And I think that is the end for me, and it'll allow enough time for Derek. And again, thank you all for your concern and flexibility.
Kim, thank you so much for that excellent presentation. Now we're going to turn it over to Dr. D'Elia to offer some insights from VCU's evaluation. Derek?
Great, thank you, Caitlin. So for the evaluation work with VCU, it's really similar in structure to the way we approached it with ThedaCare, really very collaborative and working with the resources that are available to learn what we can learn as quickly as possible. So let's go to the next slide. Again, we have a mixed methods design with some quantitative information and some qualitative information. So for the quantitative part, pulling data from records at VCU. In this case, we struggled a little bit to find a comparison group just because, the kinds of patients that they're working with at VCU are clearly unique, and we don't have multiple sites to draw a comparison group from. So for this one, we looked at a historical comparison group. So, looking at VCU patients during this initial enrollment period, August 2016 through July 2017, and then going back in time, looking for patients who are as similar as we can tell, going back in time in the same place to, use them as kind of a benchmark for what's going on with regard to patterns in the data. And we also have some, we look at some hospital utilization indicators, and then we also look at some social determinants of health indicators in a quantitative way. And then for the qualitative part, it's really the same structure as what we did with ThedaCare, talking to a variety of people on the care teams to figure out what the major issues are, what are the major themes that come from the work that they're doing. So we can go to the next slide. Here's just a look at some of the demographics, pretty even balance of male and female patients. About 2/3 are 55 and over. And there's really, there's a mix of insurance coverage, mostly public coverage, Medicare, Medicaid, dual eligible, but about 1/5 of the patients are uninsured. So we can go to the next slide. So here's our first look at some utilization indicators. So these are for people who met criteria according to inpatient use, which here we just found people who had at least one inpatient admission in the prior year, and we looked at the utilization of emergency departments 6 months before, 6 months after, and we did the same thing for inpatient admissions. So on the emergency department side, we didn't see too much. You can see the bars just kind of move around randomly. We did see a decline in inpatient admissions for the intervention group, but it really didn't look different from the comparison group. Someone in the question, the chat feature, had asked about regression to the mean in another context. It looks like here, this is probably what we're seeing for this initial group, just some regression to the mean, at least on the inpatient utilization side. But if we go to the next slide, we see some other things changing with the people that they worked with at VCU. So here we don't have a comparison group for this data because it was just collected for people who are in the intervention. But the first line looks at the patient activation measure, the PAM score. It was done for people at enrollment, and then again 3 months later. And here we see a little bit of an increase, which is mildly encouraging. We don't have a comparison group or anything like that, but this is a measure where you want it to go up, and it did go up a little bit. So patients are indicating at some level, they feel a little more confident, a little more knowledgeable, a little more engaged in their ability to manage their own health and health care. Then we see a list of really personal concerns that Kim mentioned a few minutes ago. I think she showed you the tool they use to collect this information. And you can see at baseline, at enrollment, people indicate a variety of needs: food insecurity, housing stability, and things like that. And most of these issues, the concerns are less likely to be a concern at exit 3 months later. And again, this is encouraging. The numbers are moving in the direction that you would want them to move. So at least as a first look, this is some promising information. We can go to the next slide and see some of the main themes from the qualitative analysis. So here we just looked at, to get some more detail about, what's really happening at the ground level beyond what we see in the quantitative data. And so what we see is that the medical outreach workers are really extending the clinic services into the patient's home. And we heard a lot about early warning signs in patients' care plans where, there was a clear plan of what people wanted patients to do, but for a variety of reasons, they weren't able to follow through, and the medical outreach workers would kind of step in and intercept and figure out, what the problems were. And, the problems are really very idiosyncratic. They're very different for each patient. And what the medical outreach workers are really doing is they're doing a lot of translation of information. It often happens, patients are in the clinic and they might think they understand what to do, and they may even tell the doctor, yes, I understand what I'm supposed to do. But when they get in the home, you get a different story. And we heard this many times, that patients can have more open conversations with the medical outreach workers than they would with the clinicians. And here's where we actually heard the opposite story from what we found with the paramedics with the uniform. Here was emphasized that the medical outreach workers are not wearing scrubs. They don't look like nurses or physicians. They look like regular people. And that seemed to be the thing that their patients appreciated. It's just a very different look on what seems to be going on in order to build trust. So that's that one. A lot of the common problems faced by patients that the medical outreach workers are able to help with are things like health literacy. Transportation is a big one, getting people access to medical transportation, and access to healthy foods, or even just knowing what foods people can eat on a limited budget. And we saw lots of examples here where the medical outreach workers will look and see, what do people have in the refrigerator or the cupboard, and have a conversation about whether that's really the best thing for you on your diet. And in some cases, they might even make a list of things that you might buy at the dollar store or at a discount grocery store within a budget. What are the healthiest options that would be available to you? That's a big part of what's been going on with the medical outreach workers. In terms of where we think we see the highest yield thus far, it seems to be the patients who get the best outcomes are the ones who have some motivation to take better care of their health, but they just don't know how. Their health literacy is very low. This is where the medical outreach workers can really be very helpful. And having some family support is also a factor that came up. If the outreach worker cannot just talk to the patient, but talk to a spouse or an adult child or someone like that, that seems to be very helpful in getting what appears to be positive outcomes. Kim mentioned the role of the college education, and this came up a number of times in our discussions, really for reasons that Kim had mentioned. At least for the way this program works, having the college education just helps with some of the analytic skills, some of the data skills, and navigating some of the technicalities in the health system. It seems the community health workers in this program draw on that quite a bit. And I think it also stood out that the medical outreach workers have a good deal of autonomy in how they manage their patient responsibilities. So, one example that really stood out is that the medical outreach workers have these debit cards with a limited amount of funding on them, which they can use to buy something for a patient if they need it. It could be something simple like a pill organizer or a bottle of water to take their medicine. This was described as having the ability to solve $10 problems on the spot. Something really simple that you don't want to wait 2 or 3 days to get permission. You just sort of do it, and they have some autonomy to use their judgment to take care of issues like that. And then the final thing that came out, at least at the time when we did the interviews, which was it was last summer, 2017, back when we did this, the enrollment criteria, what you look for, is something that was still under discussion at the time. It was continuing to evolve, but I think Kim might be able to say more about where the program is now, because this information might be a little dated just because of when the interviews were done. So I think I can stop there and turn over to Caitlin.
Thanks so much, Derek. Terrific insight. So now we have a number of questions for Kim. The first question is related to who leads the team and what type of training do the CHWs and MOWs?
Okay, can you hear me?
Yes, Kim, we can hear you.
Okay, actually they all report to me. There's 8 in all. The Robert Wood Johnson Foundation originally funded 2 positions. With the funding ended, 1 position is rolled into our operational budget. So there was a couple of questions about that might be answered here. One of them, both of them would have been, but Kaswana went on to nursing school. So we kept Brianna, and she is now part of our core funding. All 8 positions report to me directly.
Great, thanks, Kim. And can you just touch upon some of the trainings that you provide to the CHWs?
Yes, so I bring in, fortunately in the environment that I'm in, academic health system, I have lots of access to training around me. They have all kinds of training around specific disease management, so you name it, we can make that happen. But I also bring in individuals to teach motivational interviewing, cultural diversity, interviewing skills, time management, all kinds of core competencies. What I did when I first started trying to get them ready for certification, the state of Virginia just offered certification in May. prior to that, I started looking around the country to figure out what states had community health worker certification and what the core competencies were, thinking that if Virginia ever did offer it, I wanted to make sure they were going to be ready. So I started to look at what those core competencies were and started to line up those trainings. And so, you know, things that you would think about for that: navigation skills, advocacy skills, cultural diversity, you know, those are the kind of things that I made sure that they had skills around.
Thanks, Kim. We have a question that relates to the type of medical support that are given to the CHWs. Do nurses or doctors ever go out with them? And are there frequent interdisciplinary meetings?
Not as a practice, they don't go out. We've had one or two occasions where there was a patient where a nurse went out to the home to do a demonstration or to teach a patient how to use a particular medical device in a home setting, where the outreach worker did not do the demonstration, but it is not part of the program in general. What was the second part of the question, Caitlin?
The second part was, how frequent are your interdisciplinary team meetings?
Every morning at 7:15, there is a call. So every part of that interdisciplinary team has the opportunity to call in at 7:15. It's a quick 15, 20-minute call. Who's in the hospital, who's being discharged. Every Tuesday, the entire team meets in person to talk about patients. So there's a quick call every day, and there's an in-person meeting every Tuesday.
Thank you. All right, we have a couple of workforce-oriented questions. I'll do my best here. How do you ensure that your CHWs don't get burned out? And what is the average caseload?
Burnout. I don't know if I have an answer for burnout. I think it's probably just, I don't know if there's a formula for that, as much as we're just pretty, in my case, I'm just personally pretty closely connected to them. You know, we're a pretty close team, and aside from me, they're close to one another. So there's not a formula. There's not a particular strategy that, you know, they're close. Aside from me, they're close to one another. They cover for one another. They complain to one another. They celebrate with one another. You know, so I don't know that I have a particular formula. They fuss at me. They fuss at each other. You know, they do what they need to do. So I don't necessarily know that I have an answer, that I've nailed it down yet. But I guess I feel successful because I continually work on it, and I know that I don't have an answer. So I guess that keeps me working on it. The caseload. Go ahead. I'm sorry.
I was just going to say, Kim, correct me if I'm wrong, but I think your reflection logs in some way are an attempt to really ensure that you're, as you said, I think so eloquently before, it's not what they say, it's you're listening for, you know, inferences or what they're not saying to kind of mitigate some burnout or potential fatigue with Brianna and Katrina.
I would agree, and I guess I think the fact that I'm aware of that I don't have an answer for it makes me always aware of it, if that makes sense at all. And I think the caseload varies because it depends on, if you think about the fact that they're working with different patients in different stages of their interaction. So there are patients that they're just picking up, that they're just starting to work with. I would say during the funding cycle. So now that the funding, this is shifting. During the funding cycle, they may have been juggling at any given time maybe between 12 and 15 patients each community health worker at a time, just depending on where they are. But you got to think, there are going to be some patients that are very, very new, and they're just starting to know them. There are going to be some patients in that bundle that they are seeing once a week. There are some patients that they're just calling on the phone at some point. There are some that they're going to visits with. So it just, you know, they're not all having weekly visits or weekly phone calls. So it's just going to depend on where they are in their process.
Great, thank you so much. All right, we have a two-part question that relates to social determinants. The first is, what social determinants screener do you use, and can it be shared? And the second part is, do you assign Z codes, social determinant ICD-10 codes, for providing social determinant services?
Okay, so both of those, I'll have to get back to whoever is asking that question with our data analytics team. The tool is the Health Leads tool, but I'll have to connect whoever's asking that question with our data analytics team.
Kim, this is Caitlin. I might be able to help. It's my understanding that you do not currently capture Z codes for the social determinants, but we certainly, we can connect with Alicia and get that information out to everyone.
Yeah.
Okay, we have a question. Everyone was intrigued by the medical outreach worker debit card. Is there a dollar limit on those cards?
Yeah, they have a $50 card, and it's the typical card that you can get in the grocery store or whatever, like a Visa or a MasterCard. We have quite an elaborate system running behind the card where they have to keep up with it, and it's managed. Basically, when they get down to about $40, they turn in all their receipts and they get another card. But as Derek said, they can solve basically $10 problems with that card using their own discretion. So, as he said, if they're with a patient, the patient hasn't had anything to eat, that's more important than whatever the outreach worker's talking about. Take them to Subway, get them, swipe the card, buy them lunch, keep up with your receipt. They also are required to put a note in the patient's medical record that they purchased a Subway sandwich for Mr. Jones on Tuesday, whatever the date. And so that kind of helps us, maintain the medical record and keep a trail. So yes, that's how we use it.
Great, thanks so much, Kim. We just have one final question. What recording apps do the CHWs use for the reflection log?
I don't know if I know that, Caitlin. I can circle back to you. I don't know if it's anything specific. I don't know if it's a name on it. I just know that they record, like the voice recording on their iPhone is all I can tell you right at the moment. And it's not a specific like app from the App Store, but I will look into it. And if there's a way that we can communicate it back out, it's nothing sophisticated. They just record it and save it on their phone, and then they save it as a file.
That's great, and this is a terrific segue to next steps, because we're really happy. If you recall, Kim, we interviewed you and your team members on the reflection log. We have a tool that will be forthcoming on how to use the reflection log and develop one at your own site. In addition, you'll receive a follow-up email within the next 24 hours, which will include a link to the survey. We'd really appreciate your feedback, so please fill that out. And we have part 2 of the series, addressing social determinants of health, coming September 10th from 2 to 3:30. The registration link will also be sent to all of you. So thank you so much for joining us, and there's 2 resources at the bottom if you want to learn more about ThedaCare's work as well as VCU, and those are available at the CHCS website. We appreciate everyone's time today and hope you have a wonderful day.